Good afternoon, everyone. My name is Manu Sethi, and I'm working at Texas Heart Institute. This is my first invite here, and I'm very privileged to talk here. So thanks, Dr. Muralidhar, for giving me the opportunity to talk about assessment of mitral valve repair. We do a lot of mitral valve repairs at our hospital, of course, minimally invasive. Part of my talk was already discussed by the previous two speakers, but I'm going to repeat it because repetition is sort of always helpful. So this is my hospital. So the way we teach our fellows, we have 10 fellows a year, and the way we teach our fellows is to simplify, have a methodical approach to the echo in the operating room, because the patient has already had a previous echo done with a diagnosis of mitral valve regurgitation. They come for repair, we bring them in the OR, line them up, intubate them. So pre-bypass examination and a post-bypass examination. And the focus in the pre-bypass is on a bunch of things. I'm going to go over those one at a time. Is to check for the etiology, the mechanism, the location of the leak, remodeling concept, which is a very important concept because that tells us which valves can be repaired and what is the likelihood of a successful repair of a mitral valve. Quantification of the MR. I'm not going to spend too much time on that because the previous speakers have already gone through that. Probability of SAM, and then check for the predictors of failure or repair. And we'll go over these one at a time. Broadly speaking, there are three etiologies: degenerative disease, functional MR, and rheumatic heart disease. Degenerative, broadly speaking, are two diseases. There's Barlow's and there is fibroelastic deficiency. What we think of them as is two ends of a spectrum. This is how sort of we think about Barlow's versus the fibroelastic deficiency. Barlow's disease, I have the 2D and the 3D image video playing on the right-hand side. Usually these patients are of younger age group. They have a longer onset of MR. They have chronic moderate to severe MR. There is multiple segments involved. There is myxomatous deposits in the leaflets that causes the excessive thickening of the leaflets. There is excessive tissue leaflets, amount of the tissue in the leaflets itself. And if you could do an M mode through the leaflets, their thickness is almost like more than 3 millimeters or so. They always have dilated annulus, and there is some degree of calcification depending on where you catch them in their disease process. As I said, they have excessive tissue, elongated cords, high chances of chordal rupture. On the flip side, you have the fibroelastic deficiency. These are usually older patients, more than 60 years of age, generally speaking. They have an abrupt onset of MR. They will usually have an isolated segment involved. Doesn't mean they can't have all segments, but isolated, generally speaking. You can see like a P2 involvement over here, P2 prolapse. The leaflets are thinned out and they're transparent versus thickening, myxomatous looking sort of lesion. The annulus is dilated, of course. So the difference between the two is that, again, as I said, two ends of the spectrum. They both have an increase in the annular area, the leaflet area, the AP diameter of the leaflet, prolapse height. They increase in both, but they're much more exaggerated in Barlow's disease versus fibroelastic deficiency. Functional MR. Functional MR is a unique etiology. And there are separate criteria for that if you go look for it. These patients usually have structurally normal leaflets. They're normal leaflets. And the reason they have the main mechanism of MR is because you have an LV that dilates, and because of dilation that pulls on the papillary muscles, which causes pulling on the chordae, and that causes tethering of the leaflets, and that's what causes the MR. So you can have ischemic or non-ischemic. Non-ischemic is usually dilated cardiomyopathy, and ischemic is what we commonly deal with in the operating room. Again, ischemic MR is much more common with inferior or posterior myocardial infarction. Why? Because the posterior part of the annulus is least well supported, and the inferior MI will involve the basal part of the LV. What that does is when the LV dilates and stretches out, the papillary muscle gets pulled out, and that causes MR, which is much more common with inferior or posterior MI. Why not anterior? Because anterior MI usually affects more apical segments. And because of that, because the basal part is generally spared, it doesn't tug too much, it doesn't tether the leaflets too much towards itself. Also, the anterior leaflet is very well supported because of the aortic valve intervalvular fibrosa that is very well supported. And this is the point I want to make. I want you to focus on, this is the inferior MI. You can see inferior MI causes the basal segment to get pulled out, which pulls on the papillary muscle, and that tugs on the cords, which causes the MR, versus anterior MI, which is more apical involvement, and there is not much pulling or tugging on this part of the leaflet. Hence, inferior MI more sort of causes the MR versus an anterior MI. Okay, rheumatic MR. We don't see much rheumatic MR in US, but it's very well prevalent in third world countries, of course. It involves the entire mitral valve apparatus. There is leaflet thickening, retraction, there is chordal shortening, commissural fusion, a lot of calcification, mitral annular calcification, subvalvular apparatus. So these, by the way, these red things that I've had, these are sort of the take-home points from an echo board standpoint. So the leaflets have restricted motion both during systole and diastole. This is an echo board tested question. Rheumatic mitral valve, restricted motion happens both during systole and diastole. Repair is generally a challenge because of a lot of calcification. It has a high failure rate in rheumatic heart disease. The mechanism is well-defined Carpentier classification used across the world. Type 1 is normal, type 2 is excessive, type 3 is restrictive leaflet motion. This is the type 1. On the left-hand side, I have the annular dilation because of the stretching of the annulus, which causes the leaflets don't coapt with each other, and that's what causes the MR. Versus the other thing you can have is you can have endocarditis or lesion that can cause perforation here, which will cause the MR. So that's the type 1 where the leaflet motion is normal. Versus type 2, which is excessive leaflet motion. This is prolapse, and this is flail. You can see the anterior mitral leaflet is flailing in here, clearly. This is excessive leaflet motion. I want to make a little picture over here so you can see the difference between billowing, prolapse, and flail. This is, again, a tested question. People ask, what is billowing? What is prolapse? How do we define that? So billowing is when the body of the leaflet is above the mitral annular plane, but the leaflet tip is below or at the annular plane. Prolapse is when both the mitral, the leaflet body as well as the tip both are above the mitral annular plane. That is what differentiates between the two things. So this is billowing, this is prolapse, and this is flail, of course. And these are the moving images of the three things. Carpentier type 3 classification is restricted. First is rheumatic mitral stenosis, classic hockey shape appearance of the anterior mitral leaflet you can see here with a lot of calcification. And the other one is ischemic restriction. Because of ischemia, there is LV dilates. It just causes retraction and tethering on the leaflets that causes type 3 Carpentier classification. Location, 3D is your best view. Live 3D, you can look at the images. You can look at the valve leaflets, which is involved, which is not. You can put a colored Doppler on it. It is still not there yet because it slows down your frame rate. Hence, the resolution is not very good. It's a slow-moving image. But you can put some color on. You can show it as an en-face view to the surgeon. Well, this is where the leak's coming from. So this is where 3D really, really helps us to localize some of the lesion. Cleft versus groove, important thing for post-op issues especially. Cleft is when these are indentations in the posterior leaflet usually. If the indentation occurs or it involves beyond 50%, involves more than 50%, almost touches the annulus, that is a cleft versus groove, okay? That is a cleft and that's a groove. So here you go. On the left-hand side is a cleft. I'm going to zoom on it in just a second here. You can see that it goes all the way up to the annulus, more than 50% involvement, versus the groove, which does not involve more than 50%. So those are the two different things, cleft versus groove. Remodeling. Remodeling is an important concept. Why? Because whenever you have any lesion in the heart, okay, in this case MR we're talking about, it involves not only the mitral valve, it also involves the left atrium, the valve leaflets, the subvalvular apparatus, the ventricle, and that whole thing, because the longevity of the MR will remodel. There will be some structural changes in it. And those are important to know before bypass because they help us quantify or make a decision which patients can have a successful repair, which patients cannot have a successful repair. So that is why remodeling concept is an important thing. We're going to go over these three things here. Remember that the mitral valve closure is basically an interplay of two forces, right? There's the closure forces and there is tethering forces. When the tethering gets really bad, the closure gets affected, and that's when the MR happens. How do we check for ventricular remodeling? Well, we measure the end systolic and end diastolic diameter. So you can go to transgastric short axis view, and you can freeze the image and put a caliper in there. You can measure the end systolic and diastolic measurements. If the end systolic is, say, beyond 40 millimeters, more than 4 centimeters, your systolic function is now impaired. That's what it's telling you. It's not emptying out completely. So if you have increased LV end systolic, LV end diastolic diameter, EF is decreased, less than 50%, okay? That indicates that ventricle has remodeled. And because of that, the repair results may be unpredictable, okay? The keyword is unpredictable. That does not mean you cannot repair. You can still repair it, but the results may be unpredictable depending on how bad the remodeling has happened. We always forget about right ventricle tricuspid valve. In the olden days, we used to say, well, fix the left-sided lesions, the right side will get better on its own. That's no longer the case, okay? So when you have left ventricle with severe MR, that pressure gets reflected back into the pulmonary veins because there is no valves between pulmonary veins and left atrium. Gets reflected back into the pulmonary circulation, you get pulmonary hypertension. And if you don't fix the lesion, that reflects back to the right ventricle, and you start having right ventricular failure and TR. And right ventricle gets affected by right ventricular hypertrophy, dilation, and those were discussed in the previous talks, how to measure those. One thing we do is we measure the tricuspid annulus in late diastole. Anything more than 4 centimeters is a bad sign. So besides that, you can also quantify. You can do vena contracta, more than 7 millimeters, and the Pisa radius of more than 9 millimeters. Those are sort of your cutoff marks, which says above this is bad TR, okay? It's something really bad. So the current recommendations are that if a patient comes in for mitral valve surgery and you have severe TR, do annuloplasty. If the patient comes in for mitral valve repair, you have moderate TR, but your annulus is 4 centimeters or above, you should still do an annuloplasty. So that is the current recommendation. Most of the surgeons will sort of follow this guideline. There is a multi-center trial going on right now. I know Texas Heart is part of that trial to quantify, and hopefully soon we'll have some more sort of credible results to sort of justify this. Leaflet remodeling. What happens with the leaflets? Well, all the tethering happens, which pulls the whole leaflets down. And what that does is that moves this coaptation point of the two leaflets apically. So there is an apical displacement of the coaptation point. The more apical it goes, that means more leaflet remodel has happened, that is more tethering has happened, that is it's more advanced disease process. So what do we look for? We look for tenting height, and I'm going to show you a picture in the next slide here, and a tenting area. So numbers beyond 0.6 centimeter of tenting height and the tenting area more than 1 square centimeters tells you leaflet remodel has reached a phase where it may not be the best repair, okay? It may be challenging. That's what it's telling you. This is how you measure it. This is long axis view at end systole. You can basically put your little calipers right there at the mitral valve annulus, the hinge point, and do a quick annular height and just draw it out, and that gives you a tenting area. This is how you do this tenting height and the tenting area. Leaflet remodeling, the tethering can be asymmetric or symmetric. Asymmetric when you have an infarction, like posterior infarction. Symmetric when you have really bad dilated LV because of ischemic cardiomyopathy or dilated cardiomyopathy, which just has a symmetric dilation that causes symmetric tethering. Symmetric will cause central MR, which is right here. You can see both the leaflets here. They are symmetrically pulled down the apical. You see the apical displacement of the coaptation point causes severe central MR. Versus asymmetric, which in this case you can see the posterior leaflet is really restricted here. You have an eccentric looking MR jet. So why leaflet remodeling is important to know? Why do we look for those things? Well, because in functional MR, when you have severe MR, you can put an annuloplasty ring. That will decrease the area of the annulus and hence decrease the MR in the immediate aftermath, okay? But the tethering process is still going on. We have not done nothing to the tethering process. That will make the repair fail sooner or later, and hence these patients will come back for a reoperation. So this is why in functional MR, annuloplasty type 3 lesions in particular are most likely to have recurrent MR after annuloplasty, okay? Annular remodeling, well, we measure the annular dilation. More than 4 centimeters is bad. We measure it at end systole in the long axis view because that is the high axis, high end of the mitral valve. Mitral annular calcification, the longer the process goes on, there's more calcification. Calcification is bad, repair is bad, okay? It does not hold well. This is one slide on quantification of MR. I know it's been discussed in the previous talks, which goes over quantitative vena contracta, the regurgitant volume, regurgitant fraction, jet width, et cetera, et cetera. So you can go into any textbook and look for these sort of numbers, which quantifies them as mild, moderate, or severe. Assessment for SAM has been discussed again in the previous talk. I'll go over it again. The whole point is, in the next slide I'll show you, that the coaptation point of the two leaflets should be away from the LVOT. That's the whole goal, okay? If it's towards the LVOT because of any reason, because if you have a long posterior leaflet, which moves the whole coaptation point towards the LVOT, or you have a long redundant anterior leaflet that gets sucked in because of venturi effect. In other words, your AL-PL ratio less than 1.3, that means longer posterior mitral valve leaflet, causing less ratio. And the C-sept distance, which is the coaptation point to the septum, the highest, the peak point of the septum, that distance less than 2.5 centimeters is a bad sign, okay? Small ventricle, septal hypertrophy, not a good sign. So again, this is normal. If this coaptation point moves towards the LVOT, anything that will make this move here will cause a possible SAM. And this is what it's showing, a long posterior leaflet or a long anterior redundant leaflet which gets sucked into it because of venturi effect. So when the mitral valve repair happens, when you do the annuloplasty, what that does is the surgeon is moving the coaptation point away from the LVOT so that the chances of SAM are less, okay? That's what the surgeon is essentially doing. Besides increasing the coaptation height, which is an important concept. So what can the surgeon do for SAM? Well, avoid undersizing the annuloplasty ring size, first of all. If you have long anterior leaflet, excise part of it, okay? Make it smaller. If you have a long posterior leaflet, you can do a sliding valvuloplasty where you basically cut part of that with the cord attached and move it a little bit further up. Essentially, you're moving the coaptation point away from the LVOT. You can do neocords. You can make Gore-Tex cords and pull the whole leaflet again back into the LV. Again, the whole concept is away from the LV outflow tract and hence decreasing your chances of SAM. Predictors of repair failure. Well, repair is usually reserved for degenerative MR, number one, and some cases of functional MR. Which cases of degenerative MR are less likely to have successful repair? Annulus more than 5 centimeters, measured at end systole, remember that, okay, in long axis view. Severe mitral annular calcification, that just does not hold well. The sutures don't hold well. Repair will not be very successful. And multiple scallop involvement. In functional MR, because there is a continued remodeling and the tethering going on, you can decrease the annular size, but the tethering is not stopped, okay? So if the tenting height is more than 1 centimeter, tenting area more than 1.6, those patients in functional MR have a higher chance of having MR in the due course of time. That is why repair is not very successful. And of course, beware of SAM, which we just discussed. So now, you've repaired. You got an Arnab Goswami in there who wants to know right now, how are we doing, okay? So you tell the surgeon, Arnab Goswami, take a chill, have some water, let us assess the valve first, give it some time, okay? But surgeon wants to know right away, right? We all have the surgeons in our hospitals. So post-bypass examination, your focus should be residual MR, if there is any, to quantify and localize that. If there's any mitral stenosis, you quantify that. Any SAM, and LV function. Those are the main 4 things that we focus on. The goal is to have no to trivial MR. Moderate or severe MR is not good. First of all, any MR is bad, period. Okay? Any MR, long course, you're going to have high morbidity, high mortality. So any MR is bad. Mild, none to trivial is okay, but anything beyond that is not good. So we need to reassess that, what to do about it. 3D, of course, helps in localizing the leak, where the leak's coming from. What do we do? How do we measure these things? In post-bypass cases, because it's a different hemodynamic situation, vena contracta helps you a lot. Vena contracta more than 3 millimeters, that means it's in the moderate range, is bad. Also, we can use color flow Doppler and see how much of the area of the left atrium is being covered if the MR looks really, really bad, okay? So those are the 2 things that we sort of focus on. Remember, sometimes it's not as bad as it looks, okay? You just come off bypass. The LV is a little stunned post-bypass with the PG and all. Your hemodynamics are not good because you're tachycardic, you're on some sort of pressors, you're on inotropes and chronotropes. You're hyperdynamic, you're hypovolemic, low SVR. All those things affect your evaluation of the mitral valve, okay? So optimize the hemodynamics, tell the surgeon to take a few minutes, let's reassess in a few minutes again, okay? Well, now you've done it, and you still have more than mild MR. So what do? So remember your medical school oath, do no harm. Okay, look at your patient. If your patient is like Virat Kohli, who does very well, looking good, no pressors, okay, we should go back and revise the repair or replace the valve if that's what the surgeon thinks is appropriate. That's his call. But if you have a sick patient, who's on multiple pressors, I've got another few minutes. Multiple pressors, rocket fuel, well, then you need to reassess and make a decision as to whether to go back or not. Okay. Why do you have leaks? You have leaks because you have uncorrected prolapse. You have unknown cleft that got unmasked while they were doing valvuloplasty. Inadequate coaptation height. The whole goal of annuloplasty is to have the coaptation height of more than 8 millimeters or 1 centimeter at least. Okay. Persistent tethering and mitral replacement may be necessary in these cases. Mitral stenosis, when you put an annuloplasty ring, they all have a decrease in mitral valve area, so you all will have some gradient. Add that to the fact that you are immediately off bypass, you have tachycardic, hypotensive, on pressors, hyperdynamic circulation, that will increase your gradient as well. So give it some time. Doppler is your best friend. Do your Doppler. Mean gradients of 8 and above are not good. So that's what sort of differentiates good versus bad. SAM, again, either 5-chamber view or long axis view. If you have an LVOT velocity more than 2 meters per second, early closure of aortic valve in the M mode, lot of turbulence, lot of MR, not a good sign. But all these patients first make the physiological changes, okay? So stop the inotropes, conotropes, slow the rate down, fill the volume up, and switch to increase the SVR by phenylephrine, vasopressin, whatever drugs you guys like to use, and then reassess. Give it a few minutes, then reassess. If you still have bad MR, well, then something needs to be done about it. So this is, again, an image. Pressures are 80s. You can clearly see the SAM over there being sucked in. You can see the severe MR. This is the step up of the gradient. This is your sort of dagger-shaped gradient that you can see right here. And the next is the M mode image, which shows the early systolic closure of the aortic valve. Again, 3 things that you look for in SAM. And again, optimize your hemodynamics before you make a decision. Other assessments, LV function. You can have stunning of the left ventricle. You can have circumflex artery injury. I've seen it. It's not good when it happens. RV function can be because of poor protection. Air embolism happens. You can have newly developed TR. Those patients usually have some stunning, so give it some time. It usually should get better, but keep an eye on it. Make a full comprehensive echo exam pre and post bypass, okay? These are the 3 references. I have these very good 2 papers. If you're interested, I can show you. You can make a, take a picture of it. But these are for your library, and I want to especially thank Dr. Feroz Mahmood from Beth Israel Hospital for giving me these pictures and videos to use for this presentation. Last, I just want to go over this quick cartoon here. That is not as bad as it looks, okay? This is a 2nd grade student who was asked, what do you want to be when you grow up? And draw a picture. So she said, when I grow up, I want to be like mommy. And she has a little pole with her mommy with long hair smiling and looks like a pole dancer. And people around here with money bills. So the teacher was in shock. She sent home, what's going on? And the mom said, well, dear Miss Nolan, I wish to clarify, I'm not now. I was never an exotic pole dancer. I work at Home Depot, and last year there was a blizzard last week, so we were sold out all the shovels. And there was only 1 shovel left, and all these people were around me giving me money to buy to compete for that shovel. So that's what this is, but I'm not an exotic pole dancer, okay? So again, it's not bad as it looks sometimes, okay? So thank you again for your time, and Jai Hind.